Welcome to Voices in Value-Based Care. I'm Beth Houck. Thanks for tuning in. The movement to value-based care is revolutionizing how healthcare providers get reimbursed for delivery of care. In this program, we're going to explore stories from the field about how real organizations are dealing with this change. You can follow the show on Twitter at #VoicesInVBC and follow me on Twitter at @VaHouck. On the program today, I have with me Dr. David Ellis, who is the president of Academic Urology and a member of the executive committee for Midlantic Urology. It's a single specialty practice in Pennsylvania with about over 70 doctors and 46 locations. We're going to be talking about his reflections on his first year of MIPS from that perspective of managing this via a large specialty practice. Dr. Ellis, welcome to the show.
Thank you very much. Looking forward to it.
Why don't you just kick us off by just telling our guests a little bit about yourself and a little bit about the organization that you work at?
Be happy to. We are the largest urology group in Pennsylvania, but we are really Philadelphia. And there's a 5-county metro area where pretty much almost all the urologists who are not employed by a hospital are now working in this organization, which is a single tax ID. It's a far cry from where we all started out in medicine, which is putting out a shingle, setting up a shop, and taking care of patients. Now, because of the governmental, economic, and competitive environment, we all had to kind of group together. And so while hospitals are buying each other and insurance companies are merging with each other, same thing for doctors and in this case, urologists. So we are that now large group.
So as a single specialty large group in a metropolitan area, then do you have affiliations with a number of different health systems?
We touch them all. There's 17 or more specific hospitals that have also grouped up into ever shrinking numbers so that there's 2 or 3 major health systems left, but we interact with all of them. But then we have to interact with ourselves as well to help coordinate care. But that's getting into this paradigm shift of, God forbid you get paid for the work you do. Now we're actually getting paid for the work we don't do. And that's what value-based medicine is now supposed to be.
Yeah, let's use that as a segue to jump in a little bit. So tell me about how value-based care is different from the single specialty perspective. You know, I myself and our organization does a lot of work with multi-specialty practices. We do obviously work with single specialty practices as well, but I would say your situation is more unique because of that setup. Tell me what that means to you guys.
Well, as a surgical specialty, more or less, we would greet patients in the office and we would wind up often treating them via some sort of operative intervention. And those specific interfaces, if you were, with the patient are events that you charge for. But as the payer system changes, we now are going to be responsible for populations of patients or specific groupings of disease states where we cover all of prostate cancer or all of a certain insurance company, certain aged patients. And it's almost the old HMO stuff from the 1980s on steroids, I think is the phrase. And that requires a whole lot of systematic restructuring. Paper files don't work because we can't do data analytics on paper files. And so as a larger group, we then have the resources where we can play in this arena.
How quickly are you seeing some of this change? I mean, how much are you being approached by, say, commercial payers to take on risk or anything related to Med Advantage plans, for example?
Disappointingly, it's actually quite slow. It's all you ever read about in all the industry literature, but it's simply not happening. And so we're in this schizophrenic circumstance of actually running a per-click type of typical medical practice while we're trying to prepare for a value-based payment structure that might wind up covering 10% of our patients in 5 or 8 years, but you still have to run your regular operations anyway.
Yeah, we call that the 2-canoe issue, having your feet in 2 canoes at the same time. And it's probably the number one theme I hear when I'm talking to folks like yourself, which is just simply, how do I do 2 things at the same time that really are kind of not necessarily in concert with the other? One could hurt the other, in fact.
Well, you hope for the best and prepare for the worst. And that's pretty much how everybody's diving in. Or if you just give up, then you surrender, close your practice, and sell it off to a hospital. But you're looking at the survivors who have all grouped together, and they basically push their practice into this brand new big practice, but they own it, so they have control. And so that's really where we are. But we have at least 2 different electronic medical records systems, and we still have to do data analytics. The government is pushing this MIPS macro program on us after meaningful use. And again, it is difficult when you have disparate vehicles that you use to record patient data. But that's where you guys come in.
That's right. Well, tell me what your first reaction was when you heard about MIPS. I mean, I love hearing the answer here, but it's just, you hear that, okay, here we go. We're going to now consolidate meaningful use and PQRS into a single program. Here's MIPS. How do you respond? What was your first thought?
I was just about as thrilled as when I heard about sequestration. Create a tax, it's never going away. And same thing with meaningful use. The original stuff, we're going to reward you with a certain amount of money so that you can invest in this infrastructure, but it wasn't enough. It certainly didn't cover our costs, and the reward really didn't pan out. And that's what you typically expect, not to sound too cynical, but that's just how it goes. Nevertheless, we're stuck in this environment where we have to play or die, so we're playing.
When you heard about some of the details of the regulation, what part did you feel the most secure about? You said, I got this part, I'm worried about this part.
Well, to the degree that this legislation, what did I hear? I don't know this, but the legislation was 50 or 60 pages, and the actual rule in the congressional record went for well over 1,000, if not 2,000 pages, and nobody knew what it was. Nobody knew what they had, but there was this kind of overriding thought that it was an amalgam of what had preceded, and to some degree that was true. So we'd already worked our way through that, so I figured we will wind up working our way through this, and it led to multiple vendors knocking on my door offering their services that weren't proven. And then we spent the better part of the year actually talking with 4 or 5 or 6, trying to whittle through to see who was actually going to do the job. Obviously, SA Ignite came on board because you seem to have the best grasp and technologic ability to meander through these regs.
Yeah, we do have a founder that reads every single word of those, potentially more than once. So thank you, that was nice. So what did you do in terms of educating your fellow physicians? So you haven't yet another program, you potentially need to get them to focus on things, or not, maybe that's what I hear. What do you tell them about that, or how do you educate them?
Well, it's all, sadly, it's mostly negative. A regular mentating physician understands that this has very little to do with healthcare or improvement of the care of his individual patient. It has a whole lot to do with having him do more work for the same or shrinking dollar. So it's all kind of negative. Now, how do you get a whole bunch of people to go along anyway? Is by pointing out the negatives. And if everyone refused to do it, then they're looking at a 4 to 9% cut in Medicare, and Medicare is a very large insurer to our population as urology. So you cannot simply walk away from that without giving it a concerted thought. So then the next thing is, fine, you do it. leave me alone. I want to take care of patients. And so then it's up to the organization to offer a platform and a methodology that will help all of these doctors kind of get on with their day. In the meantime, every doctor feels hugely burdened by the fact that they have become nothing more than physician data entry clerks. And sadly, that's what much of these regulations require. And so we have to get rather creative of how to keep the doctor away from the keyboard as best as we can, because the amount of time being spent on administrative tasks are just killing what's left of the enthusiasm for medicine. But
tell me about getting creative. Tell me maybe an example of something you did to help keep them away from the keyboard, yet helping to improve your compliance with a quality measure or with potentially one of the measures of EHR adoption.
Well, it was really looking at the different measures available to us and figuring out the ones that didn't involve the doctor. And then putting it on our ancillary staff, mostly the MAs, who are directly working with patients on their intake of information. And the more we can delegate that to employees who view it as their job to do this type of function, and the further I can get it from the doctors who don't view this as part of their job, the better off.
Yep. Was there any concern that the measures themselves didn't match up well with urology? Certainly the ECQMs are very primary care oriented, and I'm not sure that the market has yet caught up to all the specialty things. So what was your reaction there?
Oh, yeah, typical, classic. You know, why should a government program make sense? And so, yes, all of a sudden we have to measure things that have no business in urology. Okay, it's just another government plan. It's just how the ball rolls.
Got it. So besides the kind of the operational shift that you just described, so, you know, getting the MAs to do some of this, did you have to, and let's just say SA Ignite aside even, are there other investments you had to make that were unexpected as part of compliance with this program or any of the other value-based care programs that are slowly eking in?
Well, look, one of the large frustrations is the fact that we use an electronic medical record or electronic health record that is a proprietary urologic product, and there is a chronic debate over who owns the information. And so it is very hard to get our own data out of our own system so that we can do data analytics with it and even make it available to you. And that is a chronic ongoing problem, not just with this vendor, with several. And so they see it as an opportunity to kind of corner the market because they own my data, even though I own my data. So we've had to put some resources in that, and that still goes on as an annoying bit of a problem. I guess we haven't even begun to approach contracting, but we do need to do that as the insurance companies mature and then really do start looking for value-based contracting. We then have to beef up on our side to figure out, okay, what are all of our costs really? And then so we put them into a contract that economically makes sense for us and the insurer. Everyone understands that if we do the work, it's cheaper than if a hospital does the work, but there's a lot of effort before you cross that line. There
sure is. Have you been able to get any, we'll call it a twofer, for the work that you've put in related to MIPS? So, for example, you know, you're helping to track a diabetes measure in a way that you never did before, and therefore you bring it to a payer so that you can get some incentives. Has that kind of thing been discussed or put in place?
Each time we've attempted that, the payer ultimately said, your urology, you're too small. But we have actually gotten twofers because this is still an organization going across a big geography and has to develop its own culture. And this regimentation forces culture development. And while everyone has to agree, you're going to answer a question with a yes or a no, then everyone at least agrees. Now they have to put down yes or no. And that starts corralling everyone into swimming in lanes, shall we say.
Yeah.
And then that has benefits across the organization. It allows us to develop better subspecialization so that not necessarily every one doctor does all these operations. Well, we actually have a few that are really very good at this particular operation. So now we start moving patients to those particular physicians, and it all runs in tandem. So it is a twofer, but people mourn the loss of typical independent practice of medicine. Whether it proves to be better, we will see. But it is certainly what we have to do based on the new reality.
Makes sense. We just did a presentation on using MIPS as spring training. So we use that analogy and kind of the whole notion that you're practicing for the regular season. The regular season being your, I guess, more fully value-based care world. And so putting these kinds of things in place are what you need to do so that you can practice. And so it sounds like you're doing some of those things.
I agree with that analogy, except it is painfully slow. It's like a 10-year preseason. The government is changing its mind on what the rules of the game are. Oh, we're playing baseball today. No, we'll play football tomorrow. No, wait a minute.
I know. I extended.
I especially enjoy that in 2018, 30% of my alleged reward or potential penalty will be because of the cost of my doing business with patients, which I actually have absolutely no control over because the cost measures have nothing to do with the costs that I generate. And yet I'm going to be held responsible on some reasonably random methodology. Just another government program.
Yeah, we're going to have some future conversations about costs because that one is just, it's a tough one. And it takes, even if you did have control, I can offer commentary that it takes so long to change. The things that end up costing you a lot take a long time to shift. So it's going to be an interesting, very slow, long preseason.
People who are listening, they should understand that I get a plus if I record a patient's blood pressure, and I get a minus if I do not record the patient's blood pressure. Fair enough. But I also get a minus if I record the blood pressure and it's high. Now, really? I'm not a blood pressure doctor. I'm a urologist. And so by random selection, I have patients who are or are not hypertensive, and certainly it's good for me to record it, and we make notes and we send back to their primary care doctor, but I don't have any ability to influence that blood pressure, but I will be held accountable for it.
Right. Like we talk a lot about outcomes measures versus process measures. It's fair to potentially hold you accountable to a process measure, i.e. taking the blood pressure so that you know what it is, but not necessarily fair, if you will, to hold you responsible for controlling it because you're only seeing them on a one-off basis.
It's so funny that you would use the word fair twice when you're dealing with a government.
So, from your perspective, if you were, let's take that little comment about the government. From your perspective, if you were to give them advice and say, here's what you need to do to more appropriately work with the unique single specialty practice set up, what kind of advice would you give them, or what kinds of things would you change?
Well, I would focus on measures that are germane to that specialty. And if a patient has a skin cancer, that's certainly something that you want the dermatologist to note. But if the patient has an enlarged prostate, you don't need the dermatologist to note that. It doesn't add or augment anybody's health care. Right now, we're looking at measures that have no regard or respect for different types of doctors that are out there, and there are plenty of different types.
Yep. What advice would you give people? So we have the full year behind us, and so hindsight's 2020, right? What kind of advice would you give another practice that, say, decided not to do anything this year and is just starting out?
Well, you need to do a cold-blooded analysis of your revenue, and first you have to find out how much does the penalty mean to you, and that's pretty much federal program patients. And if you don't treat a lot of those patients, then the amount of cost and effort and time that you're going to put into getting to this place won't be worth your while. Mm-hmm. It's much more difficult, shall I say, to look at this as a reward, because the reward continues to change, and not surprisingly, the reward continues to get smaller. So for the carrot shrinks, but the stick is staying the same, that people are simply have to figure out, based on this stick, based on how much penalty, if this is going to make sense. And there are plenty of doctors where it really makes sense for them not to bother, and for that matter, to stay on paper. And quite candidly, they get done their work quicker, and patients are more satisfied because they have way more eye contact with the patient than with their doctor, and so the doctor who is looking them directly in the computer screen instead of in the eye.
Yes, we've heard a lot about that. So just thinking a little bit, again, back to your year, anything that was a huge surprise to you? So you thought it was going to go a certain way, it went somehow differently, like anything that was a significant surprise?
Yes. That's a good question, because I enjoy this answer. If you think of this entire program as a test, and you're going to get a score, and if your score is less than 4, you're kind of getting a penalty, and if your score is above 70, you're supposed to get a reward from one pocket of money, and if it's above 75, you get a reward from a different bucket, if you will. But it very much depends. You take the test, but then depending on who you get as a scorekeeper or the teacher who's going to score your test, your test score changes. And one would have expected that this would be fairly black and white. And that was the biggest surprise. The huge variability in scores that our test receives depending on who we worked with. And that speaks to the talent of the test giver, or, the SA Ignites or the others who are out there. But needless to say, there are ways to improve your score that are all legit, and with the program, you just have to follow the rules. And so we were happily achieved a much higher score at the end when we submitted than at the very beginning, having not changed any information in the patient's medical record. So there you go.
Yeah, knowing how to play the game the right way is really what you're talking about.
It's knowing how to simply follow the rules based on what the rules are. Just follow the rules. But again, there's a variability of people or of organizations who are in a position to do it well. So it makes a difference. Yes.
Well, last topic I wanted to just end with is the reputational impact. So the scores, although we haven't seen how they'll be published, we haven't seen them out there, we haven't had the opportunity to hear any hub or buzz in the market around the scores being out there. What's your perception when the scores get public? What's your organization's concern or not around them, and what do you anticipate happening?
Well, you can't worry about what you can't control. And so everybody will have a problem with their scores. And it's easy. And that's happened, heart programs got scored, and cancer programs got scored, and hospitals got scored. And there were so many caveats that in order for the general public to truly understand the score and actually get meaning from it, that would take too much effort. So instead, it has newspaper blitz value for about a week, and then it goes away quietly into the night. I do very much expect that my own patients will look up my score, and it won't be in the context of, oh, well, you know, even though you got a 92, there are a whole bunch of urologists that got 93. It'll just be some raw score, and people will assume that a 92 is great, and they won't know if it was good or not good. Okay. So it's a frustrating aspect, but at the end of the day, people, at least right now, still don't pick their doctors based on that kind of information. They do pick their doctors based on what they think it will cost them, and then if they think they're going to a quality doctor.
Well, that's a great place for us to end. It almost cues up another episode, because I certainly would love to have more conversations about how people choose doctors and how we can be more transparent about cost, but that would take us a whole lot longer. So I want to just thank you again for your time, Dr. Ellis. It was really great talking to you.
My pleasure. Thank you very much. Good luck.
Thank you. So thank you, Dr. Ellis, and thanks to our audience for tuning in. You can learn more about the show on the programs page on healthcarenowradio.com, and lend your voice to the conversation on Twitter at #VoicesInVBC. And be sure to follow me on Twitter at BA Houck. I'm Beth Houck, bringing you the voices in value-based care you should hear. Until next time, have a great week.